Good afternoon, everyone. And you know that we start on time, like the speaker, right? So we do not start late. So thank you so much for coming to the Health and Government Operations Committee. For those of you watching at home, thank you for joining us. And for our members, thank you so much for always being on time. I really appreciate you. So I am Jocelyn Pena-Melnick, the chair of the Health and Government Operations Committee. I'm joined by my vice chair, Delegate Bonnie Collison. And today we have the honor of having Speaker Adrian Jones join us for our briefing. And I'm going to, she's going to say a few words to us. And I want us to please welcome her warmly. Oh, come on its own. Yeah, it's on.
Okay, it is on. Thank you, Chair Pena-Melnick and Vice Chair Collison. I look forward to the presentation and working with the committee on this issue. I don't believe in talking long because it's not why you're here. So let's get it moving. So.
Thank you. Thank you, Speaker Jones. We really appreciate your leadership. So I kindly ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on Maryland General Assembly YouTube channel. Before this briefing, all members were emailed a copy of each presentation. I know staff is amazing, so I know you all got it because thank you so much for putting this together. And today we have our wonderful Erin Hopwood, who is our lawyer on these matters. And I want to thank her in advance for all the work and lining up all the witnesses. Please, to the committee, adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, because then we'll be here all day and I want to get you out on time. Please keep your questions brief. Please keep in mind that this briefing is scheduled to conclude at 3 p.m. Yesterday, we finished at 2:51. So I want to do the same, okay? Today, the Health and Government Operations Committee will hear from the Maryland Hospital Association on improving hospital throughput and emergency department length of stay. As you know, we have the worst waiting time in the nation. The committee will hear an update on the total cost of care model, the AHEAD model, and improving emergency department wait times from the Department of Health and the Health Services Cost Review Commission. We will also receive an update on the Office of Minority Health and Health Disparities from the Maryland Department of Health. I would like to personally thank Delegates Bandari, Delegates Shalega and Martinez for participating in the hospital work group. And you spent a lot of time this past fall, and I thank you for doing that. And before we get to our first person on the panel, I like to say happy birthday to our own Delegate Bagnall. I hope you have a blessed year and thank you for being such a great member of this committee. We will begin with Erin Dorian from the Maryland Hospital Association. Ms. Dorian, will you please give us your presentation? Please come out with your panel. I believe you have the Senior Vice President and Chief Medical Officer, the Associate Chief Clinical Officer of the Maryland Medical System. Whoever you have, they can come up with you. And good afternoon, how are you?
I advance my presentation before we get started.
So if you can, right there. Actually, you have someone coming to assist you.
Perfect.
I know it works. It's wonderful when it works out, right?
It is. It is. Thank you so much for having us here today. Dr. Babakar and I are very excited to talk to you about all the work we've done, and we're very excited to have you, Madam Chair, here for our presentation. For the record, my name is Erin Dorian. I'm the Vice President of Policy at the Maryland Hospital Association. I'm here representing Maryland's 60 hospitals and health systems and their 110,000 employees who go to work every day to care for every Marylander across the state. Next slide. Before we get started, I just want to level set for a second on what hospital EDs are. Maryland's emergency departments care for 1.7 million patients a year. They provide an important access point for many Marylanders. Data shows that nearly 90% of these patients are discharged from the ED, meaning they do not need to be admitted into acute care. That's not to say that all of these patients did not have an urgent issue or that they had another option to access the care that they needed at the moment that they needed it. Hospital EDs are open 24 hours a day, 7 days a week, 365 days a year, and they care for anyone who walks through the doors. The emergency department is more than just the front door to the hospital. We spent a lot of time last year talking about how long it took for patients to walk through an ED's doors, be triaged, wait to be seen, be treated and discharged. As you said, Madam Chair, we do rank last in state rankings on the average time all of that takes, and we all want to do better. And that's why we're here. We've all been working really hard and want to continue to work together to reach the goal of reducing that time. Next slide, please. In a moment, I'm going to walk through the stakeholder group process that was requested by the chairs of Finance and HGO. But I want to take a moment to update you on what the hospital field is doing collectively and what individual hospitals are doing to solve this problem. The work goes beyond the individual hospitals to the entire hospital field. In a moment, Dr. Babakar will talk about what one system is doing to improve their wait times. I also want to acknowledge that it goes beyond the focus on the emergency department. We've talked extensively about the healthcare workforce issues over the past several years, which is undoubtedly impacting a patient's ability to access care and a hospital's ability to move patients through the ED. MHA and this committee has partnered together since 2021 to develop solutions for our workforce crisis. Last January, MHA launched our Join MD Health digital campaign, seeking to bring people to explore careers in healthcare. I encourage all of you to visit the site joinmdhealth.org and take the quiz to find out if you are a head, hand, or heart. Now on to the ED specific work. In May 2023, MHA launched a 10-week learning collaborative on ED crowding. Then in July, under the leadership of Dr. Malik Joshi, CEO of Meritus Health, in his role as an HSCRC commissioner, the HSCRC launched the Emergency Department Dramatic Improvement Effort, or the EDI. I'm sure the HSCRC is going to talk to you about that in a moment. In August, the MHA launched a performance improvement collaborative, which works in tandem with the EDI and is aimed at improving performance on the EDI measures over the course of a year. We're bringing every hospital together to work on this PI initiative, which will run through July 2024. Next slide. I too want to thank Delegate Bandari, Delegate Shalega, and Delegate Martinez for their active participation in the work group meetings throughout the summer and fall. And I want to thank you, Madam Chair, for staying engaged with the group and providing me with advice and counsel throughout this entire process. The group consisted of 27 representatives from hospitals, provider groups, and consumer groups. We met monthly from July through this month in person for 3 hours each meeting. We are continuing our work. We haven't finished yet. Our last meeting will be on Friday morning, where we will finalize recommendations before submitting the report to you. We also added an additional virtual meeting in December to ensure that the group had enough time to cover the very extensive request. In October, MHA brought in Health Management Associates, a leading healthcare consulting firm, to assist as the group moved towards recommendations and bring in additional expertise given the complexity of the issue. Next slide. The work group identified 4 top issues as contributing factors to the longer ED lengths of stay. These are hospital capacity and emergency department boarding, the behavioral health crisis, healthcare workforce shortages, and limited access to care outside of the ED. This is including primary care, access to SNFs, and access to behavioral health. While these factors exist in other states, there are some specific ways Maryland is unique that may be making us experience these pain points more acutely. Next slide. When we talk about hospital capacity, we're talking about the total number of hospital beds in the state. But more importantly, we're talking about the number of staffed beds. This is the number of beds ready to receive a patient. What you're looking at here is the raw total number of beds throughout the state. As you can see, between 2015 and 2019, on average, this number went down. It's starting to tick up a little bit in 2019. On the right-hand side of the slide, you can see that Maryland has the 5th lowest number of hospital beds per 1,000 population in the nation. Next slide. Several work group members highlighted hospital capacity, occupancy, and emergency department boarding as significant contributing factors in ED length of stay. Boarding is defined by the American College of Emergency Physicians as the practice of holding a patient in an emergency department after they have been admitted to the hospital because no inpatient bed is available. The red line on the bottom shows the total number of boarders on average per day. The slide shows the 7-day average staffed occupancy rate across all hospitals in the state in the green line on the top. In a paper published in the New England Journal of Medicine, several chairs of emergency departments at academic medical centers discussed the relationship between hospital occupancy, ED boarding, and other hospital throughput challenges. They concluded that, in general, at occupancy rates over 85%, ED functional space will be reduced, and there will be higher levels of patient boarding. As you can see, we consistently range above 85% in hospital occupancy. Next slide. The group also discussed the ongoing behavioral health crisis in Maryland and how this contributes to emergency department lengths of stay and hospital discharge challenges, which I don't think is that's no surprise to any of you here. You all have been working on this issue for a very long time, and I want to thank you all for the significant work you've done. Over the past several years, this committee passed a bed registry bill, which has increased visibility into psychiatric beds, stood up the Commission on Behavioral Health Care Treatment and Access, and bills to approve access to crisis services and so much more. We know that we still have a lot of work to do, and we look forward to continuing that work together, but we do believe that that work will help bring down our emergency department lengths of stay. Next slide. The group also discussed the importance of addressing the healthcare workforce crisis extensively, but we also acknowledge that the Workforce Commission is coming up with a comprehensive set of recommendations. The workforce has not returned to pre-pandemic levels, and we continue to talk about not just nursing shortfalls, but shortfalls in other allied health professionals. And the work group was very clear that other positions that keep the hospital and health system running are just as important. So our environmental services, everybody that keeps the hospital running. Without intervention, these shortages will only grow. These shortages impact a patient's access to care outside of the hospital and a hospital's ability to fully staff to the volume of patients that come through the door. Next slide. So I want to preview the recommendations for you with the caveat that the group is meeting one final time on Friday to confirm all of the recommendations and confirm prioritization. HMA was engaged in October of 2023 to independently facilitate deliberations of the work group and to help us categorize the recommendations. This was done in several ways by HMA. They conducted key informant interviews independent of MHA with state leaders, a consumer advocate, and hospital leaders. They went on 2 emergency room site visits to hospitals in different parts of the state to better understand the challenges facing hospitals on the ground. And over 2 meetings of the work group, they broke the work group into subgroups and facilitated discussions around potential recommendations. Along with the recommendations developed in this formal setting by the work group, MHA distributed a questionnaire in mid-October to work group members to solicit potential solutions. 7 members submitted 17 solutions. These responses, along with the output from the work group deliberations, were condensed by HMA into 28 individual recommendations and presented to the work group in December. You don't see 28 here. This is just a flavor, but I can answer any questions about the recommendations when we're done. The group then worked through a prioritization exercise at the December meeting, which we will reaffirm the prioritization this week. Every recommendation will be in the final report. The group's recommendations generally fall into 4 broad categories: statewide process improvement, access improvements, workforce recommendations, and then additional recommendations that don't really fit into any of the above categories. I don't want to read these word for word, but I do want to highlight a few. Under the statewide process improvement, the group discussed additional data tracking that providers in the state can partner to collect and analyze to understand the health system throughput pinch points. Currently, MDH and MIMS is collecting capacity data from hospitals. Through collective action, which includes hospitals, skilled nursing, and other providers, we believe we can develop a system to submit data to the state to better understand the choke points and where the patients are getting stuck. In access improvement, there was significant conversation around making sure every Marylander has access to insurance, which I know is really important to this committee. It was very important to the work group. In workforce, the group reaffirmed a recommendation from the Workforce Commission that data on the healthcare workforce should be collected in a systematic way. And lastly, improving the guardianship process was of particular importance to the hospital representatives, as there are patients sitting in hospital beds for months and sometimes up to a year who no longer need an acute care, waiting for the courts to make a guardianship decision. This backs up patients in the emergency department and is also not the right place for that patient to be. As I said earlier, the group is meeting one more time on Friday to reaffirm the recommendations, and the report will be submitted shortly thereafter. I know some of these are likely already making their way to your ears for bills, and many of the recommendations will not require legislation. I'm more than happy to meet with any one of you once you have the report to discuss any of the recommendations, or more than happy to meet with you after this meeting. Next slide, please. Before handing the presentation off to Dr. Verbacher, I want to let you know that you can use this QR code to find all of MHA's resources on hospital throughput and emergency department length of stay, including the materials from every work group meeting and the recordings of each meeting. Thank you very much for having me today, and I'll hand the presentation off to Dr. Verbacher.
And before you start, I just want to say thank you on behalf of the speaker and the committee, because as you know, the bill did not pass. And we asked you to do this work group on your own and to get a consultant, right, that will be able to help you. And you did that without legislation. So this is actually a good thing to remember to our members, that sometimes you don't need a bill. Sometimes you just ask the department and you can get it done. So we're very grateful for your time and your efforts. Good afternoon, sir.
Good afternoon, Madam Speaker, Madam Chairwoman Pena-Melick, Madam Vice Chairwoman Cullison, and members of the committee. Thank you for having us. My name is Neil Verbacher, and I have the pleasure of serving as the Associate Chief Clinical Officer for the University of Maryland Medical System. And I'm also the Chief Medical Officer of the University of Maryland, Baltimore, Washington Medical Center. I'd like to start our conversation today with a discussion on the root causes of emergency department wait times. If we were to picture the emergency department as a roundabout, there are minimal barriers with each destination, when each destination coming off of that road is the destination of home. Very rarely would an emergency department be overwhelmed if each patient went home after their visit. Once the care is delivered and the patient is treated, it takes about 20 minutes for the discharge instructions to be provided and for the patient to be on their way home and for that bed to be made ready for the next patient. As a result, focusing solutions on decreasing the volume of discharged patients will have a minimal impact on emergency department wait times. However, once you introduce an inpatient bed as a potential destination off of that roundabout, it creates a backlog of patients in the emergency department. This has an impact of all patients waiting for care, whether they need to be admitted to the hospital or whether they can be discharged. The backlog occurs due to a number of factors, including staffing, higher acuity, longer lengths of stay, complex social and chronic conditions, as well as transitions of care outside of the hospital. So the impact of boarding patients, those are patients waiting for a bed in the hospital, can be profound. Looking at the ED1 metrics of how long it takes from when a patient arrives to the emergency department to when they arrive upstairs, patients waiting for a hospital bed staying in the emergency department can wait as much as 3 times longer, if not even longer than that at times. And while a hospital may admit only 20% of the patients that come through the emergency department, those admitted patients can take upwards of 50% of the beds in the emergency department. And finally, if we presume that a discharged patient takes about 3 hours to evaluate, diagnose, and treat, for every 24 hours that a patient is admitted and waiting in the emergency department, we could see about 8 discharged patients. And so as you can see, the impact of boarding has a disproportionate impact on wait times in the emergency department. And so it's with this understanding of the workflow that our emergency department wait times are being tackled in 2 ways. First is knowing that the majority of root causes that live outside of the emergency department, we as a hospital industry have engaged our inpatient and our outpatient colleagues to improve overall throughput. These are just a few of those examples. A surge response plan where we are systematically approaching volume surges to ensure all interventions are being considered. With care transition rounds, we're ensuring we have a safe handoff from the inpatient world to the outpatient world for our patients. By minimizing variation and providing evidence-based care, we are able to create standardized algorithms for our staff. We created an expediting team that addresses barriers, a radiology test, a physical therapy evaluation, or perhaps a physical consult that needs to get done by a physician. A departure lounge for patients who have a place now to wait for their ride to get home, and allows us to be able to take that bed for another patient. And finally, close follow-up as an outpatient, so that those patients that are most vulnerable after discharge have a place to land once they leave the hospital. And knowing that the inpatient and outpatient efforts are often long-term strategies, these are very complex issues, we are also looking to make an immediate impact with changes in each of our emergency departments. So vertical care and rapid medical evaluations can bring care to the patients while they're waiting in our waiting room. Observation medicine and enhanced discharges allow for potentially longer workups in the emergency department, but can result in fewer admissions. Vertical care allows for that care to occur even when they don't require a bed. Observation medicine and enhanced ED discharge programs allow us to care for patients and potentially discharge them from the emergency department, avoiding a need for an inpatient bed when they would have otherwise needed it in previous strategies. So at the University of Maryland Medical System, we have seen the value of being engaged on this work at the state, the system, and the local levels. At the state level and through the General Assembly Work Group and the MHA Throughput Collaborative, there has been a multidisciplinary approach to identifying root causes, developing solutions, and sharing best practices. And while this presentation is about what UMS is doing, I can say with confidence that every hospital across the state is doing great work and is very focused on making improvements. At the system level, we have created a standardized surge plan, created urgency through an executive level throughput summit, and now have committees that meet on a bi-weekly basis to go after the EDDI metrics. And finally, at the local level, each hospital or member organization has a patient flow council that focuses on these three areas that we previously mentioned. At the system level, the committees meet bi-weekly now to share best practices and implement new ways of delivering care. We share how each hospital is doing and how we can help each other through a bi-daily report. And finally, with our standardized approach to dealing with high volume surges, you can see here as an example how we address volume surges in boarding in our emergency department. At a level of Charlie, we are notifying each of our organizations and shifting the focus of certain staff members. At level Delta, we are potentially reallocating staff to where the needs are greatest. And at a level Echo, we are thinking very, very differently. We are potentially canceling meetings. We're potentially using alternative spaces to care for our patients. Now, solving the emergency department wait times will not be accomplished by one singular intervention. It will also not be solved without the help of every single person and department that touches patient flow. It can be daunting and sometimes difficult to grasp. And that is where the concept of a moonshot goal came to be for Baltimore Washington Medical Center. It might be hard for certain departments to grasp how they can help improve ED wait times, but they do know how they can potentially reduce length of stay. So knowing that we are not going to be able to staff dozens of more beds with each of our organizations, we challenged our leaders to create 30 beds of capacity through more efficient processes in each of their departments. And while there's been a significant focus on the aim statements that have been submitted for each hospital, we believed it was going to take a fleet of aim statements to make an impact. And these departments for sure delivered. This is just a sampling of the 45 aim statements that we received at our organization. I highlight the ones in yellow just to demonstrate how so many different departments, inpatient and outpatient, can play a role in bed capacity and ultimately ED wait times. Examples here come from, as an example, an inpatient unit looking to improve the number of patients that get sent to the departure lounge, an operating room that is creating a process to perform more same-day surgeries rather than waiting for the next day. An outpatient practice that has created a clinic that allows for very close follow-up to some of our sepsis patients so they can avoid a readmission to the hospital. a pharmacy department that is looking to see which patients can be converted from IV to oral antibiotics, and an emergency department that is expanding their successful rapid medical evaluation program. It's going to take a village, and this is an example of how that village is coming together to help address ED wait times. So when we look across our entire medical system at the University of Maryland, there are several initiatives that have gone into place that have begun to demonstrate improvement in a variety of metrics. At Baltimore Washington Medical Center, we've implemented an expediting team and a departure lounge program to address delays in discharge. We've also initiated a rapid medical evaluation process in the emergency department to care for those patients that are getting discharged home. It's resulted in a 24% improvement in early discharges and a 51% reduction in left without being seen patients. At Charles Regional, they developed a split flow care model, again, helping to care for the dischargeable patients. And they've also partnered closely with our EMS colleagues to improve offload times, seeing a 12% improvement in EMS offload times and a 33% reduction in emergency department left without being seen. At CAP Region, we've implemented a local surge plan, as we've discussed earlier, and they've also created an expediting team to help address barriers for discharge, as just another example of each of our hospitals learning from each other. And since that work has been implemented, they've seen a 63% improvement in earlier discharges. At Shore Regional, they've implemented nurse-driven protocols to facilitate the decrease in telemetry utilization. That frees up very resource heavy and scarce beds that are needed by several patients. They've also revamped their patient and transition rounding on their inpatient units to improve communication. And so they've also seen significant improvement. One, they've seen a 33% reduction in the time waiting for an inpatient bed, and they've seen a 32% reduction in the telemetry utilization. At St. Joseph Medical Center, they've implemented a dyad physician nursing partnership similar to the AIM statements that you've seen at Baltimore Washington Medical Center that has led to length of stay initiatives that are driven within their own division and their own departments. They've also utilized predictive modeling to better predict discharge readiness and to facilitate that discharge home. They've seen almost a half a day reduction in length of stay, and they've seen a 40% reduction in the number of patients that leave without being seen. In Upper Chesapeake, they've implemented an enhanced ED discharge program. As I mentioned, it is the ability to provide resources to our patients in the emergency department and discharge them home rather than requiring an admission to the hospital. And they've also recently opened a departure lounge. What they've seen is a 33% reduction in the number of observation patients that have required hospitalization. And finally, at the University of Maryland Medical Center, the downtown and midtown campuses, they've created a real-time process that expeditiously resolves barriers for patients requiring skilled nursing facility transfers. They've implemented a vertical care process to care for those discharged patients, and they've created a new offload for EMS patients to reduce EMS transfers of care. They've seen a 35% reduction in EMS offload times at the downtown campus, and they've seen a 45% reduction in the number of patients that are leaving without being seen. So while we are very proud of these results, we know there is still more work to be done. We plan on continuing the focus on creating inpatient capacity, ensuring safe and timely follow-up. We never want to compromise quality for speed. And we want to continue with emergency department interventions, as you've seen here, and partner with others outside the hospital, including post-acute care facilities, to improve transitions of care. And finally, I'd like to personally thank this committee's engagement and interest in this topic. I'm an emergency medicine physician, and I've seen the impact of ED wait times over my 20-year career. I'm encouraged by the direction the state and our hospitals are going to address this important issue. Thank you.
Okay. So is there anyone else speaking? Is this it?
Yep.
So I first want to thank you for all your efforts. I see the efforts and that you're trying. I'm going to open it up for questions, okay? At this time, are there any questions? And there are. So I just need you to be patient. And if you do not know the answer, will you be so kind and get back to the committee? And send it to the entire committee, please. First, we're going to start with Delegate Gazzoni.
Thank you, Chair. I am not like super knowledgeable about all this stuff. So if you could explain a little bit more about vertical care, I would appreciate it, and its effect on ED process.
Sure, absolutely.
Thank you.
So many patients in our emergency department do not require a stretcher or a bed to get the care that they need. And so the concept with vertical care is that there are certain population of patients that we can quote literally keep vertical. and allow their care to be provided in a chair, getting an X-ray, in a treatment room, without taking up the space that is needed for the acutely ill patients that need that bed. And so we're being very unique and resourceful in the space that we have, and to care for the most patients possible in that space, given the limited resources and the limited capacity because of some of the boarded challenges that we have. Sure.
Thank you. Next, we have Delegate Hutchinson.
Thank you, Madam Chair.
My pleasure.
So I have the distinction of representing the hospital in the state of Maryland that has the longest ED wait times, and that's University of Maryland Shore Health in Easton. And I believe in the interim, a report came out that our wait times were almost 24 hours in Easton. Madam Speaker, the governor's office, MHA, Secretary Scott, HSCRC, I can't overemphasize enough that we need a new hospital in Easton. Now, while a new hospital won't solve all the ED problems, I do know that it does contribute to the ED problems. I had a long meeting with Ken Kozel about that when that report came out, because it was an embarrassment to me to see that my hospital had the longest wait times of 24 hours. You know, last year I sat in one of these hearings, and MHCC Director Ben Steffen sat there and said that he was streamlining the CON process. And I was delighted that the CON process was being streamlined. And I asked specifically about University of Maryland in Easton. And I sit here today still waiting for a CON to be completed for that hospital to be built. We need the CON, we need the funding. It's unfair to my constituents that we have a hospital that's that antiquated with a 24-hour wait time. When the report comes out, I would love you to come meet with my office and speak to me about it. Thank you, Madam.
You're welcome. Would you like to comment?
Sure, Madam Chair, Delegate Hutchinson, if I may. The CON process was discussed at length by the work group, and there is some recommendations on looking again at if the CON process should be further streamlined and thought about on how to ensure that we have the capacity that we need throughout the system.
Thank you. Next, we have Delegate Lewis.
Thank you, Madam Chair, Madam Speaker, to the panelists. Thank you all very much for being here. I'm looking at and thank you for your work. I know this was a heavy lift, but it was really important, so thank you. I'm looking at slide number 9 that describes the hospital employee vacancies in Q3, third quarter. And there's a really nice visualization there, a map that shows the sort of spatial differences between nursing vacancies by region. It looks great, but I'm missing something. And I'd like to know a little bit more about the denominator that underlies the percentages that are presented. Because I think by understanding better the scale, the numbers would make more sense. For example, knowing what the good delegate from the Eastern Shore just said about the need for a new hospital, I see the nursing vacancy on the Eastern Shore on this map is only 4.9%, while in Central Maryland, where the greatest majority of people happen to live, the nursing vacancy rate is 19.4%. So we know that people are not necessarily getting care quickly. We know that hospitals there are long wait times. How is it there are fewer vacancies? What does this mean? So help me understand what these percentages really reflect.
Sure, Delegate Lewis, I will answer your question to the best of my ability right now, and then I will also go back to our team in our strategic analytics department and get back to you. So we, since 2021, we MHA since 2021 have been conducting a survey of our hospitals and their current vacancies and turnover rates. I believe that that each vacancy is based off of their current open requisitions. So that is, they're currently it's the current open requisitions over total positions that they have. I will go back just to verify that that is correct, that that's the way that the question is asked. and make sure that I have the correct answer there.
You're welcome. Next, we have Delegate Johnson.
Thank you, Madam Chair. And also on slide number 9. I see that we did it statewide. We're comparing our state to all the other states in the nation for ER wait times. I wondered, do you happen to have the national average on percentage of vacancies in these fields to know if we're doing better than or worse than in some of these vacancies?
Delegate Johnson, I don't have, I can go back and find that. I think our data is better because we do this directly from the hospitals quarterly. So this is a 12-month rolling average. I know that AHA does do a survey, and we can see if we can compare apples to apples to see what Maryland is versus the nation, but it won't be as granular as this.
My pleasure. Next, we have Vice Chair Collison.
Thank you, Madam Chair. I do want to add my thanks to the work you've done. It's just terrific, and I'm really excited. And I will say offhand, this is a comment, not a question first. I'm interested in the CON discussion and recommendations because when you tell me 85% is the number that we need in order to keep our wait times down and people and discharge people, something's not jiving there. So I'm eager to see what the recommendations and discussions were. But my question is just, and I also want to say thank you for in your recommendations that you have here in this, you reference access improvements and, the importance of getting every resident in Maryland, healthcare, how important that is. So I really appreciate that. And you even reference the undocumented residents who are working, paying taxes to Maryland, but don't have access to healthcare. My question in that section, though, is it's improve access for certain complex patients and insurance access. Are those two different things, or who are or is this the behavioral health population?
So it is a Delegate Collison, Madam Vice Chair. It is two different things. So there is improving insurance access for everyone, including the undocumented. And then there is a set of patients for whom have difficulty accessing the care they need. For example, there is a set of patients who have difficulty accessing the dialysis care that they need in the community. Some of those patients may not have insurance access. So once we get them insurance, they may be able to access dialysis in the community dialysis. Other patients are unable to access dialysis because they have some kind of behavioral health condition, and they have, for lack of a better term, behaved badly at a community dialysis facility and are no longer able to go to those facilities to access their dialysis. And so although they are insured, they cannot go to a community dialysis facility, and they end up not receiving their dialysis, or because of their other conditions, whatever they may be, are not adhering to their dialysis plan and end up in an emergency department just for dialysis. So there's those types of patients. We will talk a little bit more about those patients, those kind of very specific groups of patients in our report, but those are the types of patients where we're talking about. So some of it is insurance, and some of it are patients that have complex needs and are unable to get the care that they need in the community because of those complex needs.
Sure.
So thank you. That's really helpful. But your inclusion in these recommendations means to me this is a fairly significant problem.
Yes.
Okay, great. Thank you. Not thank you that's true, but thank you for your response.
I have Delegate White.
Thank you, Madam Chair and Madam
You're
Speaker, and thank you to our panelists for this presentation. One of the questions that I have relates to staffing. And so I wanted to know if you could expound upon how our hospitals engaging employee groups in addressing ER wait times.
Sure. So there's several ways in in how we're trying to engage our workforce, if that's the question, if I understand it correctly. And we're trying to support them in every way that we can. We understand that there is a shortage right now, but we're trying to be innovative and try to think of new ways to provide that care with the staff that we have. So we have introduced LPNs into our workforce in the inpatient world. We've also introduced things such as virtual nursing. We've also partnered with schools to ensure that we can have students that are coming in that could be future nurses and future techs in our emergency departments and in our hospitals, but also providing a helping hand to our staff who need that help as well.
You have a follow-up? Go ahead. If you might be able to chime in about regarding the stakeholder group process, right? Were your staff or other employee groups a part of this specific process that you outlined as it relates to the work group that was just elevated in Aaron's presentation?
Yes,
If I can answer that, since, Dr. Babakar.
absolutely. Whoever has the answer,
Yeah.
here we have a rule. We don't want to go back and forward. So you decide who's the best person to
Sure.
answer.
Employee groups were represented on the work group. SEIU was a member of our work group, and they attended and were an active participant. So we were very happy to have them.
You're welcome. Delegate Riley.
No, don't touch it. Thank you, Madam Chair, and welcome, Madam Speaker. And thank you to our panel for the work that you've done and the commission. I had a question. Did the commission itself, did they look at any parts of like the Maryland waiver program or Maryland waiver system to see if that has any impact on the ED wait time, or absolutely has no effect on it? I don't know, because I believe we are the only ones in the country that has the waiver process. Okay.
We did have a very long discussion about, our hospital waiver, our hospital model. And I want to be very clear, we are very lucky to have the model and to have everything that comes with the model, and all of our hospitals, are focused on, all of the population health improvements that come with our model, and everything that the HSCRC is trying to do. We do believe that there could be that we can further look into whether there are some incentives, some unintended consequences in the model that may be driving this. That's not to say that we want to throw the baby out with the bathwater. There are many positives to our model, but there could be things that could be driving this, and especially leading to additional occupancy rates in our hospitals and driving up those ED borders.
And going to work on those improvements. So thank you very much. Appreciate it.
Delegate Hill.
Thank you, Madam Chair. Good afternoon, Madam Speaker. Thanks for being here, and thank you all for the work and for being here. I would like my one best question.
Yes, please. Thank you. So grateful.
to be centered on what I'm not sure you did consider and whether it was considered. So understanding that when we talk about the number of beds that are available, that's not just physical beds, inpatient, it's also the staffing to go with that. And understanding that we have a number of different emergency facilities available to people that are not integrated, urgent care facilities, 24-hour, 24/7 nursing hotlines, ERs themselves, and EMTs. Did you and are you looking at whether part of the solution is better education to the public of which facilities should be used, better integration of those facilities and sharing of information? Did you look at, when you looked at the people, I don't see social workers or physicians or scribes, ER scribes, as listed of manpower issues? That seems like they could tie things up. And did you look at whether our history of closing beds went too far, that we closed too many beds and now we have to chase ourselves to open them back up again?
Well, thank you very much, Delegate Hill. You got a lot in that one best question.
That was, if I may say, that was the best question. It's a catch-all, you know?
So let me see
Let's
if I.
get your best
Let
answer.
me see if I can deliver my one best answer. So to the first part of your question, there was a discussion about, you know, a public awareness campaign, you know, essentially, and educating the public. MHA is doing some of that, and we have some materials available on our website. We'd love to share them with you all, to share with your constituents about, you know, when is the best time to use urgent care, when is the best time to use the emergency departments. What we don't want to do is discourage anybody from visiting an emergency department when they believe that they have an emergency, or when they absolutely need the care. So we did have a discussion about that. On your workforce question, we talked about, you know, we did not talk about scribes, but we did talk about physicians and other professions that we do believe, you know, we have a workforce issue, not just in nurses, we have it across the board. But what the group decided to do from the beginning was try to allow the Workforce Commission, which was going on, to continue to do that work, and focus on healthcare workers in the ED that we thought, you know, that specific sort of niche worker that could improve throughput through the ED. So you'll see a recommendation about expanding, potentially creating a new class of worker for a radiologic tech, where a person in a urgent care center can take, you know, simple images. Because what we find sometimes is that urgent care centers don't have a person that can take a simple X-ray, and so you know, a patient is sent to the emergency department to get an X-ray. So if we can train medical assistants to take a simple X-ray, then that would relieve some of that. So we talked more. We tried to keep our conversation to that type of worker, because we had the commission going on. And then in terms of, you know, bed closures, we talked more about capacity, you know, and we didn't get really into you know, what beds were closing, or where, you know, beds may have been taken offline. What we did talk about was that often when a hospital goes forward with a CON, they ask for 120 beds, they get 95. And so that was a discussion point of our work group.
Thank you. And thank you for your patience as we ask these questions, okay? Next, I have Delegate Lopez, followed by Bandari, followed by Alston.
Thank you, Madam Chair, and
pleasure.
thank you, Madam Speaker, and thank you to everyone who contributed to the success of this work group. I'm looking at slide 10, and I want to be mindful of the time that we've asked a lot of questions, but I'm noticing under the statewide process improvement, data tracking is listed, and that's a pretty broad subject. So I'm just wondering, in very broad strokes, can you explain what data that you're looking to track? Is this new, and how do you believe it will be helpful to you in addressing the problem?
Sure. So right now, hospitals contribute to the state our current occupied beds. We contribute, I'm not going to get every single data point, but the number of boarders that we have in our in the ED, how many of those boarders are psychiatric boarders. We also contribute the number of individuals that are COVID positive, and on the and the number of open beds in both acute care units and in ICUs. At one point during the pandemic, the skilled nursing facilities were contributing the number of beds that they had open. They have, it's my understanding that that's no longer being tracked. We believe that the data that we need, we could expand from just hospitals to other facility types where, you know, hospitals may transfer patients to skilled nursing facilities or other types of facilities, so that we can have a window into where the choke points might be. And this is something where we don't think that we need legislation for this, where the stakeholders can come together, you know, the state, the hospitals, the skilled nursing facilities, and potentially CRISP, and develop a plan for collecting this data, analyzing it, and figuring out where those choke points are and coming to you if needed with some solutions.
Thank you. Next I have Delegate Bandari.
Thank you, Madam Chair and Madam Speaker, and everybody making this a priority. And I had a pleasure being on the informal group. And it's wonderful to see the recommendation. I have a question. Are there other existing initiative in the light that you highlighted workforce shortage within MHA and that align with this recommendation for potential collaboration or learning? And what additional support or resources from legislative bodies would be most beneficial for hospital to effectively adopt these recommendations?
I'm trying to think of so I think for our workforce recommendations, we really are excited that the commission is recommended that data tracking. When we looked at what other states are doing and how other states are able to grow their workforce, it really starts with the health licensure boards, knowing who we have, knowing the workforce that we have. And right now we just don't. So we think where we might need some help from the legislature is considering whether that should be a job of the boards to collect that data, to understand and report on, who the licensees are, where they are, and where they are working. We at MHA are doing that. We are happy to support that work in any way we can. So that's what we were excited to see that in the recommendations from the Workforce Commission.
Thank you. We have next Delegate Alston, followed by Delegate Taveras, and then Delegate Morgan.
Thank you, Madam Chair and Madam Speaker, for being here today. And thank you all for all of your work, and to my colleagues that worked hard on this committee as well. My concern and question is actually about the behavioral health beds. We have a real public crisis when it comes to our law enforcement officers that are serving emergency petitions and then have to take those people that are already in a very fragile state to an emergency room, handcuffed, and then they have to sit there for hours upon hours to wait for bed space. And meanwhile, our law enforcement officers are not on the street keeping us safe because they have to stay with that patient. And I know one of the things that we asked for in our county was to know when hospitals are on bypass so that they don't go there and have to wait for 5 and 6 hours before they're told to go somewhere else. I think that's a simple fix with your slide about the alpha and bravo levels. We really need to communicate that to our law enforcement partners because we're causing unintended consequences in the rest of the community. So that's the comment and the question, the best question of that would be.
I was about to say,
The
isn't that
best
so?
question
So
of
you
isn't
leave
that
it
so?
there.
But the question actually is going back to the certificate of need, and do we really need to have the certificate of need process encompassing our behavioral health and psychological services? I saw a bill recently that's going to look into that, but I think that's something that we need to look at if we need to expand bed space for mental health patients.
I think that's a great question for this committee to reflect on. If the CON process makes sense for the psychiatric beds and other behavioral health beds, I think we can work with the hospitals in your county around making sure that notification is happening with law enforcement. And I'm happy to reach out to your office after this hearing to work with the hospitals in the county to make sure that that's happening. I think that there are, as the work group talked about, there are, there probably is an opportunity to take a look at the CON program and streamline it a bit.
Well, I know there's a bill that was introduced this session, so I welcome the department and all the parties to come together and try to have that conversation with the Public Health Committee, okay? We have Delegate Morgan, followed by Delegate Taveras. Actually, I'm sorry, it was Delegate Taveras followed by Morgan. Delegate Taveras.
Thank you, Madam Chair, and thank you, Madam Speaker, for being here. And then I feel like we've got rock stars here today. I want to ask regarding on slide 14, there was a conversation regarding what's impacting the inpatient capacity. So I wanted to know, are we looking at the correlations as to why the individuals that are going to the ED have higher acuity and more complex social and chronic medical conditions? Is it that people are avoiding going for preventive care because they don't have insurance, and therefore what are the correlative factors that can speak to that? So
who's the best person?
I'd be happy to. So,
Thank you.
So Delegate, it's a fantastic question, and I think it's multifactorial. So for one, several of the lower acuity patients have moved to urgent care facilities in the care that they receive. And so the denominator, so to speak, of patients has changed quite a bit over the years. Second, we have an aging population. And as that population ages, their conditions, their chronic conditions can play a bigger role as they get older. And then to your last point around whether there are delays in care, that's certainly possible. That as patients, as we saw through COVID, delayed getting care, their symptoms, their diagnosis could get worse. And we want to make sure that they know that they have access to care, whether it's in the hospital or emergency department, but also want to make sure that they have access in the community through primary care practices to ensure that they're getting the right care that they need to prevent those acute on chronic issues that drive them to the emergency department in the hospital.
Thank you. We have Delegate Morgan.
Chair.
My pleasure.
Ms. Doran, you said something that really caught my ear when you were talking earlier, answering another question from one of my colleagues here. Can't remember which one. Talked about training his staff and helping like private businesses do like x-rays and things like that. And that would help alleviate some of the problems at the emergency room. 2 years ago, I think we passed a bill dealing with allowing some of the volunteer ambulance companies that transport patients to actually transport patients to urgent care facilities if they were contracted with the hospitals. Do you know if anything has come about that? Because that seems like a good way you might be able to maybe get offload some of the less emergency patients.
I'll have to check. I'll have to get back to you on that, Delegate Morgan. I think, that the federal government did have a program called ET3 that also would have allowed for that Maryland applied for and was a part of, at least in Montgomery County, I believe. I think that program has been discontinued at this point. I know that there are some local EMS providers that are willing to do that, and local urgent care providers that are willing to accept. But I will check with Dr. Delbert at MIMS and see where that is.
Thank you, Delegate Morgan. I see no other questions. I want to actually go through page 10, your work group recommendations, just to give you a quick update regarding the statewide process improvement, the behavioral health funding. I know the Secretary of Health put over $100 million last year for behavioral health funding. And there's actually the Behavioral Health Commission, which I believe you belong to as well. So I will like your participation in that. And then there is a bill this session to try to streamline a couple of the commissions as well. That is going to be coming our way. There is the implementation of the prior authorization reform. I know that Vice Chair Collison and Ms. Kaufman have been working with the providers and with the insurers. And I believe they have an agreement. So we're gonna see that bill, and they worked really hard in the interim on it. And regarding data tracking, I think that CRISP is amazing. They are our state HIE, and we need to use them. They're able to see who are the frequent flyers, right? Who comes often to the ER? Why is it that they're coming? You know, who are they? Where do they live? What do they need? I think that as we looked at our model, right, the model that we have, we were supposed to do a lot of investment in population health. That has not happened to the extent it should have happened. And we need to have greater investment in population health. Have the providers when people leave, invest in social workers and people that will do the hand off, right, into the community so that people do not come back. Regarding the expansion of insurance access to uninsured, there is a bill that is going to be introduced by actually the vice chair and Senator Antonio Hayes in the Senate that we would love your support, which basically requires that the Maryland Health Benefit Exchange seek a permit, a 1332 waiver from the federal government, because currently the federal government does not allow undocumented individuals to purchase insurance with their hard-earned money, right? With their money. They granted that waiver to California, Oregon, as well as Washington State as well. The bill this session has it very clear that there will be no subsidies, that in order for there to be subsidies, it has to come back to the General Assembly. It simply allows an individual that can pay with their money, no help from the state, won't cost the state, to buy insurance on the marketplace, which you know does a better job than the private market because they compare all the policies. They have navigators, right? As well. And that won't cost anything at all, right? It's allowing the person to have responsibility, right? To pay with their money. So that would take place. Regarding the data collection, I know that I spoke to the Secretary of Health, and they're working on a lot of that data collection that we require as well. The guardianship, I know I have an appointment at 4 today with you to discuss the guardianship bill as well. If there are any other bills that you want, the members that were on the work group, Delegate Shalega, Delegate Bandari, Delegate Martinez, approached them about putting in a bill that came out of consensus as well. This is the time. The bill request is Friday, so it has to be done now, today. Like stay, wait, and talk to them, okay? Usually, I don't have a lot of questions or comments, but I needed to tell you that we're working on these. Our members are really committed, all 23 members and myself and staff, on finding solutions. We're not putting it all on you, but we want you to tell us what you need because this has to improve. It is really bad, really horrible, the way things are right now. I want to thank you for all your efforts because I know it's not easy to sit where you are and to get so many questions, and you answer them beautifully. So we want to thank you and express our sincere gratitude, and we look forward to working and having some solutions in the next, how many days, guys? The Secretary of Health knows. How many days left in the session, Secretary? 83 days. Okay, so you have a blessed day, okay? And know that our doors are open, and let's find some solutions, okay? And lend your voice to a lot of these bills because your voice is needed here and across the street as well. Thank you so much. Our pleasure. Next we have, and for timekeeping, it's 2:06. We have the update on total cost of care model, ahead model, and improving emergency department wait times. We have Laura Herrera Scott, Secretary of the Maryland Department of Health, and Mr. John Crum, Executive Director of the Health Services Cost Review Commission. Welcome to the committee again.
Welcome, Madam Chair, members of the committee. Good afternoon.
Great to have you, and you can get started.
So good afternoon, everyone. Thank you for having me again. I think we have one more day this week.
You are welcome anytime.
So as Madam Chair said, we'll start with total cost of care. So I'm going to give it, turn it over to John Crum, the Executive Director for the Health Services Cost Review Commission, to give that update. But first and foremost, I wanted to share just what an incredible partnership since he's been named as the Executive Director. And we've been working very, very closely on everything you're going to hear today, including the work we have been doing, not only with the ED wait times related to HSCRC, but certainly with the Maryland Hospital Association. So, you know, we sit here before you as a true partnership and in the work you're about to hear moving forward.
Thank you.
Wonderful. Thank you, Secretary. Madam Chair, Vice Chair Cullison, members of the committee, thank you so much for your time today. We really appreciate the opportunity to come and talk to you about, I think, 3 really critical issues for Marylanders. If we could move to the next. So I'll start with an overview of our current model, right? And that gives us a jumping off point to talk about our future model, right? We think about the total cost of care model as really working on 3 levels, right? So on the first, the core of it are really these global budgets for the hospitals. The way that the global budgets are intended to work is really, it's to hold the unit costs of hospitals, so the case rates of hospitals, relatively high, while incentivizing reductions in potentially avoidable utilization, right? So that's how you drive a lot of the cost savings within the global budgets, right? And then in the next sphere, really incentivizing partnerships outside of the walls of the hospital, right? So that we make sure that transitions of care are smooth, that we're creating care pathways that are appropriate for population need. And then finally, at the community level, really setting some common goals around population health and health equity that we can roll together as a state toward. What I would say, and kind of just spoiler here for the head model conversation, where we have real opportunity here is in those 2 outside concentric circles, right? I would say that we've done a great job reducing costs within the hospitals, improving quality, and I'll talk about that in a moment. But those outer spheres are really where our opportunity exists. So this is just another view of kind of the similar construct. What I just want to point out here is that we have a lot within our hospital population-based revenue. We have a lot of incentives stacked against quality, quality of care within hospitals. And I'll come back to that in a moment. Health system collaborations. We've really worked hard, I think, in the state with our hospital partners to build programs that really create partnerships between hospitals and community providers, right, to streamline care. We'll move to the next slide. How are we performing as a model? So this slide is really, this is how CMS grades us, right, on our total cost of care model. And you can see that through the life of the model, we've performed fairly well relative to our tests. The cost savings, the annual Medicare total cost of care savings, that is really the kind of primary objective, or the primary grade that CMS is looking at. We have done well under this model in that regard, and have performed really consistently well, even during COVID, against these tests. But our real North Star, though, is what is the impact on healthcare in Maryland, right? And you can see through our total cost of care model, we have certainly reduced cost at a tremendous level, right? Through the life of the model. A really important thing, and I'll come back to this, 8.4 percentage points lower than state gross product. That's incredibly important. That's the gold standard, I think, of cost growth, right, in healthcare, right? As long as we can keep cost growth under gross state product, I think we're doing our job in terms of keeping healthcare as affordable as possible. But then also importantly, quality improvements through the life of the model, right? So we've seen big reductions in complications in pay-for-performance programs. We've seen big reductions, particularly early on, in unplanned readmissions. That's really critical because I think what it shows is that when we focus the incentives of the model, even on long-standing challenges like readmissions, we can get results, right? So hospitals can move these metrics with sustained effort. That's important when we get to our ED wait times conversation later in the day, right? So again, this is another view of how hospital cost growth is held below gross state product. Again, I think this is a really critical way to think about how we're performing with respect to cost growth. So health equity, again, I think this is an area where we have a lot of opportunity. And so the best is yet to come with regard to health equity. But there are a number of programs and incentives that we've put into place here in Maryland under the current model. And then also to keep in mind that inherently, right, holding rates for hospital services for Medicaid and Medicare higher than in other states also helps promote equity and access for those populations across the state. So the other thing that I wanted to highlight here is really revenue for reform. So number of updates here. Revenue for Reform is a new program. We just launched it that I think represents an approach as we kind of ramp up our population health focus, right, within the model. So Revenue for Reform is an opportunity for hospitals to retain revenue if they're making investments in evidence-based population health programs outside of the hospital. And we've partnered very closely with the department to evaluate those programs, right, and assess those programs, and then ultimately to approve those programs and whether they qualify for the Revenue for Reform program. So through this mechanism, we're going to drive millions and millions of dollars per year in population health investments through our hospital partners, right? So I'll end our quick update on the total cost of care model with just an overview of our kind of the financial strength of our hospitals, right? So all hospitals across the country, I think coming out of COVID have experienced financial stress. But here in Maryland, I think the model has been protective of hospital finances. We can see that balance sheets for Maryland hospitals have improved over the life of the model, while they have eroded somewhat through COVID, really not as much as their peers in other states. And in some cases, we're seeing a rebound back in terms of their balance sheet strength. So all of that gives us, I think, a jumping off point, right, to think about what comes next, right? So we've had a demonstrated success in holding down cost growth. We've had demonstrated success that when we point kind of the focus of our incentives on longstanding quality problems, quality challenges facing Marylanders, Maryland patients in Maryland hospitals. We've been able to move the needle, right? But now we really need to hook in to the strength of those incentives in this model. We really need to hook into a broader state strategy for equity and population health improvement. And so that's a lot of what we'll talk about next. But let me pause here and ask if there are any questions on kind of the current model and current model performance.
To my members, are there any question on this first part on the total cost of care model? You see none, you can go ahead to the second one.
So let me hand it off to the secretary.
Thank you. Thank you, John, for the update of the total cost of care model.
I
So
think we hear about it so much that we all dream about it, right? Go ahead.
So I wanted to take, before I jump into the next steps, and as we think about what our next negotiation with CMMI looks like, wanted to first ground you in our vision for healthcare delivery in Maryland. And this was set in place even before we heard from the Center for Innovation, Medicaid and Medicare Innovation around what's coming with ahead. And this slide is a summary of where we think we're going. We put pen to paper and sat down and say, you know, what is our North Star? What do we want to accomplish? And certainly we did this after hearing Governor Moore and Lieutenant Governor Miller give their vision for healthcare in Maryland. And this is the vision statement we came up with, which is equity and excellence in Maryland's healthcare delivery system that improves the health of all. And as you can see, this goes way beyond the hospital walls, right? So, you know, as we think about, we've done some work in primary care, as we think about the Maryland primary care model, but that was still specific to Medicare, not inclusive of Medicaid. We haven't done as much as we could be doing with the community. Post-acute care is, you know, we heard before, you know, certainly a contributor to some of our length of stay in our hospitals that then backs up our emergency rooms, and we haven't connected that part of the delivery system to hospital care, and then even palliative care and end-of-life care. There hasn't been much discussion around that, and we don't engage people in their healthcare and their healthcare choices, in their end-of-life choices and the choices they want to make it with their family as much as we could. And under all this is certainly equity. How do we make sure that this system that we're building is accessible to everyone? And if it's not, then how are we going to hold ourselves accountable to make sure that everyone has access to equitable and excellent healthcare in Maryland? Certainly community and community's role in participating in that healthcare delivery of services. And all of this is just one big population health value-based payment arrangement. And so how do we successfully deliver on all that? Now, what's missing from the slide is some of what you've already flagged as workforce. And where is the workforce going to come to address this larger vision? And certainly, what is the data that we need to deliver on this vision? Next slide. So in September, the Federal Centers for Medicare and Medicaid Services announced what we keep referring to as AHEAD, and AHEAD stands for All Payer Health Equity Approaches and Development Model. They released the funding opportunity in November, and this was the details of what they were proposing. That Medicare and all-payer cost growth, Medicare and all-payer primary care investments, and equity and population health outcomes through state agreements with CMS. And as you read this sounds pretty familiar to what you heard John talk about as far as the Maryland model. Certainly thinking about hospital global budgets, and then what they were referring to of primary care ahead, which is inclusive of Medicaid in this version, which to date we have some primary care initiatives in Medicaid, but not aligned with the rest of the model. They're looking to include equity that needs to be integrated, so it aligns with the vision that we had in place. Certainly behavioral health integration. We know people with co-occurring mental health, substance use disorders contribute to total cost of care. And so how are we going to address that in the next version of the model? Medicaid alignment, as I've already said, and then accelerating existing state innovations, which is some of what John described under revenue for reform. In all of this, the AHEAD model is designed to curb healthcare cost growth, improve population, and advance health equity by reducing disparities in health outcomes. And so where we have been so far has started some of that work, but that's where we think the real opportunity lays. It also besides the strategies for a statewide health equity plan and behavioral health integration, certainly all payer alignment on all of this work. So not just in the hospital, but outside the hospital as well. Next slide. So AHEAD builds on the total cost of care model. On the right is the model or the rings that John shared, and certainly the opportunity exists in expanding primary care and population health equity. But again, the total cost of care targets, growth targets to control healthcare spending, and you can see compared to the national average, we are doing that, including keeping our total healthcare costs among our state domestic product. Improve population health, certainly the opportunity, and then advancing health equity by reducing disparities. We're starting to do that. The hospital data is very robust in having race ethnicity data. I've previously shared in some smaller meetings, Medicaid's race and ethnicity data. So this is the opportunity to start shining the light on, are we providing equitable care? And if not, how will we transform the system to make sure that everyone gets access to the care that they need? Next slide. The Maryland health model is important to our state. So we've already demonstrated controlling hospital cost growth while enhancing quality. But this second bullet is certainly unique, and the third bullet, guaranteeing equitable funding of uncompensated care. I would say Maryland does a better job than most other states in this bucket. And then stabilizing hospitals to ensure access to care in all parts of the state. So I don't know if you've listened to some of the media around hospital closures in other states, especially rural hospitals. Maryland has not had hospital closures or service line closures because their budgets were protected under total cost of care to ensure access to services everywhere. Equalizing hospital charges for all payers, and then again, early in supporting population health and health equity. And certainly losing the model would deprive Maryland communities of all these benefits. Next slide. So having said all that I've said, it highlights the importance of our hospital system, and it leads us to why AHEAD. So the current total cost of care model agreement is set to expire in December of 2026. CMMI developed this AHEAD model as the federal policy approach for state implementation of population-based payment models. Outside of Maryland, Vermont has a rural AOC, and Pennsylvania has global budgets for their rural hospitals, but there's really no other state doing this work. And so given the success in Maryland, they really wanted to move the model forward. And in our discussions with them, they've made it clear to us that AHEAD is the pathway to continue to secure the Maryland model, and is the vehicle with which we will be renegotiating the terms of the Maryland model. Next slide. What brings Maryland to the table? As I mentioned, all the details of the AHEAD model pretty much mirror the Maryland model. So we have the fundamental building blocks for what we need to be successful, our long history of successful financing healthcare on an all-payer basis, certainly harnessing existing momentum to align with health promotion activities. And that's not just health promotion activities that the hospitals are doing, but health promotion activities that the department is doing. And how do we align those activities within the department with activities with the hospitals? Maryland Medicaid has partnered for decades on the Maryland model, especially on inpatient, but how do we now think about that partnership outside the four walls of the hospital? Developing a robust Maryland model governance structure to provide oversight of what we will be doing, expanding Maryland's experience managing Maryland PCP or primary care program will help advance the goals of primary care across across all payers. Technical expertise in establishing and improving global budgets. Again, 95% of our hospital are already on global budgets, so we have experience doing this work. And then decades of investment in our robust data infrastructure. Chair Peña-Melnick, you've already called out CRISP as the data utility for the state, and arguably one of the fewest states in the country that has the tools and resources that CRISP can deliver on behalf of the hospitals and our community providers compared to other states. Next slide. So this is a crosswalk of the different features of the AHEAD model, our total cost of care model today, and AHEAD, and what we are doing. So you can see there's already much alignment, and again, setting us up for success. Next slide. We are looking for stakeholders to help advise us on what the submission in May should be to CMMI. So there are currently 3 advisory committees that have been set up. The Population Health Transformation Advisory Committee, and it's to advise the state on the approach to equity-centered population health improvement. As we go into the next version of the model, we will be expected to have a statewide health equity plan. Certainly Primary Care Transformation Advisory Committee. So how do we take what we have around Maryland PCP and build an equity-centered approach to value-based primary care that's inclusive of Medicaid, including pediatricians. To date, many of our pediatricians which care for our kids have been left off the table. And then certainly Healthcare Transformation Advisory Committee focus on Maryland's healthcare delivery system, all payer cost growth targets, and this is really hospital centric. As part of this advisory committee, we had 160 applicants that included clinicians, public health experts, consumers, academic institutions, hospital and payers, and those meetings will be kicking off next week. I would also be remiss without pointing out, we do have legislative representatives on each of the TACs, as well as a variety of healthcare community members. Next slide. So here's the timeline for AHEAD. So our submission, it will go in March. The potential award announcement will be May 2024, and then an 18-month period for negotiating will occur in the pre-implementation period. We did have the opportunity to consider different cohorts that start at different times, but we really wanted to leverage our leadership in this space on global budgets, on total cost of care, to go in the first cohort, to lead by example for the rest of the other states that might be considering. So we will be competing early on for the federal funding, and we think it'll provide us more time to negotiate the new model terms prior to the end of the 2026 date, which is December of 2026. So with that, that's my last slide on AHEAD.
Thank you.
We'll take questions in the end and
We'll do it at
transition
the
to
end.
ED. Okay,
Okay.
back to you, John.
Great. So now zooming in on a specific challenge that's that's facing, you know, a longstanding challenge that's been facing Maryland patients in Maryland hospitals. You know, when we look at ED wait times, we certainly you know, agree that this is a complex and multifactorial challenge, right? Over the last few months, it's been a core focus of the HSCRC to look at ED wait times. Our colleagues at the MHA mentioned the EDDI project. I will walk through a number of other initiatives that we have in play here. But we recognize that this is again, long-standing challenge. You know, we have had very long ED lengths of stay for as far back as our agency has tracked them, right? So, and that performance gap has remained relatively unchanged. So again, this is a complex problem, and you know, you'll hear throughout this presentation, the HSCRC and the department are really working together, but we're going to take, you know, this is going to require a lift from all stakeholders around the state. If you move to the next. So We recently did an analysis of root cause for ED length of stay. We analyzed data from all US hospitals to identify some of the underlying factors that contribute to long ED wait times. Certainly, there were a number of kind of what I would call structural factors that contributed to it, right? So Maryland hospitals tend to be larger and more complex. Larger and more complex hospitals tend to have longer ED wait times, right? So there are structural challenges contributing, certainly. But a lot of what we found was that hospital occupancy is a really important determination of ED wait times. That occupancy challenge, again, as we heard earlier, contains a lot of different drivers within it, right? So surgical volume, inpatient length of stay. Inpatient length of stay is a really big one. Small gains in inpatient length of stay can result in massive reductions in some cases in ED length of stay. End of life, ICU days, nursing home access, all of these were factors that weighed heavily in our modeling, right? I think what a lot of our modeling demonstrated, though, like inpatient length of stay, hospital level interventions can be effective here. Can it account for all of the drivers? Certainly not, right? There are access challenges that we have to address outside of hospital walls. There are factors outside of hospital walls that we have to address, but there are certainly things that can be done at the hospital level that can be effective. And as we heard earlier, there are many hospitals around the state that are already focusing on them and doing them, right? I just visited our friends at Franklin Square the other day. They're doing some amazing work, for example, on utilizing telehealth technologies to improve their staffing levels in their ED and getting really good gains out of that, right? So we know that there are things that can be done within the hospital to contribute to these challenges. So policies that may improve ED wait times, right? Just like there are a range of factors that drive ED wait times, there are a range of potential policies that could improve ED wait times. Certainly, again, in addressing inpatient occupancy, in addition to the factors that exist within the hospital, improved hospice access, improved palliative care services, SNF access. We've heard that many, many times today. You'll continue to hear that. Improved behavioral health access in the community, and then operational efficiencies within the hospital. Improvements in primary care. We do believe, right, that that ED wait times work on essentially 3 levels, right? First is ensuring that we're preventing preventable utilization in the ED. Primary care access is a really key contributor to that. Then there's the hospital throughput challenges, which are in many cases tied to inpatient occupancy, but also other operational factors. And then there's ensuring that there's a place for patients to go, right, outside at the community level, right, when that is the appropriate care that they need. And then finally, addressing social determinants of health. I think what we've seen here in Maryland is as the acuity of our patients has gone up in our ED, in our EDs around the state, it's also come with more challenging social needs, right? So we have a lot of social determinants that social needs of our ED patients that I think certainly contribute to the ED wait time problem. So I want to highlight here that new hospital beds are not really a good blanket solution, right? Now, is that to say that there are no new hospital beds needed across the state? Certainly not. What I'm saying is that it's regional, right? So, you know, we've heard a lot about the CON process. Certainly we work closely with the MHCC and want to make sure that that is as streamlined a process as possible. So depending on the region, that may be necessary. But what I'm saying here is that we here in Maryland have an opportunity to match our capacity and access to our population needs to ultimately ensure that the right care is being delivered at the right time, right? If we take a blanket approach of just increasing inpatient beds, right, it's essentially amounting to a very expensive Band-Aid solution, right, that isn't necessarily matched with what's best for the patient or what the patient wants. So I think as we move forward here, one of the things that we really do need to keep in mind is let's make sure that we're matching capacity and access to our population needs. Other solutions also within a hospital can reach the same goal. We just heard about some fantastic work out of UMS to increase the capacity within their hospital through operational improvements, decreasing length of stay just to 2019 levels, so pre-COVID levels, would create an increase of staff bed capacity by 246 beds across the state. So again, regional approaches, right? Some hospitals have more opportunity than others, but we know that these opportunities exist. So incentives for improving ED length of stay. As I mentioned in our first discussion, one of the approaches that we've taken in the total cost of care model is pointing incentives against quality challenges that we're experiencing here in the state. It puts kind of a sustained focus on these challenges, and we have seen good outcomes. Because of the complexity of this challenge, we are looking at a number of different approaches, right, to try to reduce or improve ED length of stay. So we certainly have some programs in place in partnership with the department to increase access to primary care. Again, reducing the number of people who need the ED in the first place, right? Second, we have some incentives that are under development today on the overall length of stay within an emergency department. We're working with our stakeholders right now to identify that measure that will move into payment. And then we're also looking at other incentives, really targeting best practices within the walls of the hospital. And then finally, as we move forward, again, we're looking forward to working with all of you and other stakeholders around the state to make sure that we're increasing capacity in the subacute settings of care, right? So again, just want to focus on a couple of things that are in play right now. We're working on currently. There's the EDDI project. This is both collecting real-time data on ED lengths of stay, making sure that that's available to the entire state, right? And helping to support with our partners at MHA rapid cycle quality improvement. All hospitals have submitted goals, and then we're going to be tracking progress against those goals over time. The quality pay for performance program, again, we're going to incentivize overall reductions in ED length of stay, but we also recognize that, hey, there are some factors that are outside of the control of hospitals. So we also need to make sure that we're putting incentives on specific and targeted aspects that of the challenge that hospitals can control. One of them that we're working on right now is a potentially avoidable utilization policy, where we incentivize hospitals to manage care for patients who are in the ED more than 4 times per year. So we're working with stakeholders right now to develop that. Now, there are a number of hospitals today who have programs in place to identify those patients, work with those patients, make sure that they're getting to the right setting of care that they need, make sure that they're addressing their social determinants. We want to be a partner in enabling those innovations to happen, right? And then finally, not listed here, early stage of development. Coming out of the EDDI project, we're identifying lots and lots of best practices, both that are occurring in the state, but then are also occurring outside of the state. We will be gathering those up and then developing some incentives around ensuring that the highest leverage best practices that hospitals can do, we're incentivizing those, right? We'll be working with hospitals throughout the year to do that. So let me pause there. There's a lot in that presentation. I'm happy to deep dive on any of it. But again, I think the takeaway here is, yes, it is a multifactorial challenge. There are things that we need to do outside of the hospital, but there are also things that we need to move inside of the hospital at the same time to improve ED length of stay.
Thank you. So I'm going to open it up for questions now from our members. And I see Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here. This question, I'm not sure if you can answer, somebody could answer or get back to me. This would go back before I was on this committee when Pete Hammond was the chair of this committee. There was on your slide, you say community, primary care, you're starting in the community. A bill was passed, a program to expand community health care and community health centers. And gosh, 10 years ago, maybe, again, it was before I was here, but then Eric Barron, Delegate Barron, expanded that program. Great program. I worked with them, supported it to really kind of focus in equity and patient populations. Often, as you said, managed care for patients 4 times or more per year, frequent flyers in the emergency room. What's happened to that program? I mean, we put millions into it. Is it still alive? We were told it was going to really help patients in the community. And I did see it work in some instances, but what happened to it?
So I don't know the specific program that you're referring to, but I can tell you we work with our community partners regularly, especially our federally qualified health centers. So I'd have to get back to you on the specific program and the dollars that were invested. But even as the state health department, we have partnered very closely with our FQHCs, the rates that they get through Medicaid and some of the wraparound services that we provide through our public health arm.
But this wasn't federally qualified. These were community health grants. A lot of them focused, and I didn't think you would know because you're new. And how could you possibly know all the myriad of programming that we have? But this was focused a lot into county health departments and city health department and grants. Didn't we have like to hire some physicians into, do you recall the program?
And what we'll do is we'll get the bill, because it was Delegate Barron's, and we'll send it to the secretary so she is aware of it. And if you will be so kind and give us an update on it.
Will do.
And Erin counsel is right here, so she'll get it. And when you send it, counsel, will you be so kind and CC Delegate Shalega? My pleasure. We have next Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
Secretary Herrera, John, good to see you. Thanks for the presentation. And that really does make me feel so fortunate that the people of Maryland have smart and dedicated people working to solve the problems. My takeaway was that the total cost of care model is working and we want to preserve it. It's just going to take a new shape or a more informed and vigorous direction with this AHEAD initiative. So we're still going to be the only ones in the United States saving money in a smart way. I'm curious to know a little bit, to understand a little bit better how the sort of whole the health, what was it? Senator Nathan Pulliam bill on healthcare, health for all. Why am I having a stroke?
The health equity.
Thank you, the health equity
Yeah.
and the statewide approach to integrating health equity in all that we do.
Health in all policy.
Thank you, Madam Chair. This is why you're the chair.
This is why I'm the chair, but it takes a village, all of us together with council here. Go ahead.
But it was so important because it, set a line in the sand that we're really going to center health equity in all that we do statewide, every agency. And this is a great, this AHEAD program is clearly a great opportunity to move us along that path. I'm curious, how does the health equity analysis, sort of a stringent and systematic health equity analysis, play in to the decisions that you'll make going forward?
So, other states have done some of this work already. And as I've shared, HSCRC through the hospitals has great data. And we know we have pretty good data. We have about a 90% match in Medicaid. Medicare and commercial depends. But it's to start shining the light on where we're not providing services. So for a variety of reasons, we know we have regional differences in access to health and health outcomes, and that could be travel distance to a facility. That could be the way to travel to a facility, personal transportation versus public transportation. That could just be access to broadband and being able to, dial in for a telehealth visit or other reasons. But then we also have real disparities in healthcare, either because we don't have good matches of providers and services, because care is not culturally appropriate. So one of the things that we're looking at is all the places, all the data sets we have access to, and to start breaking down that data in a way that helps us say, well, is it equitable across? So you could imagine looking at a diabetic measure, for an example, and breaking it down total, and maybe totally we look okay. But when you start breaking down in race and ethnicity, breast cancer screening is a perfect example where we hit the mark overall, but when you break it out for Black women, the number drops, and the number of Black women getting their mammogram is lower. And why is a variety of reasons as well. But those are the kinds of ways that we're looking to break down the data and then be very, very, very intentional about the programs we build to get people into care.
A very minor follow-up, and just for housekeeping, it is 2:48. We still have one presentation. So I'm going to just ask the committee for patience. Today, we're gonna go a little over, but they're important. And I will try to get you out early when I can. I will do my best. So I just need a little flexibility today, okay? Thank you so much. Go ahead.
Thank you, Madam Chair. I remember hearing about a health equity dashboard that we could look forward to from the department. Where does that fit into telling the story about equity and using data to make better decisions?
So the Health Equity Dashboard is part of the Health Equity Commission, and I will say we have been remiss in delivering on that dashboard. So the dashboard is coming, but much later than I think the original bill intended for it to come. So it should be available, hopefully by summer of this year, now that we've identified the data sets that we have. But we should have delivered on that already and have not.
Great question. Thank you. May I have Delegate Olson, followed by Delegate Collison, followed by Delegate Bagno, followed by Delegate Hill? No, I can cross you? Wonderful. Thank you. How about, pass? All right. We're making progress here. Bagno, pass? All right. We have
It was that good a presentation, huh?
Delegate Hill, followed by Delegate Rosenberg.
The luck runs out. You knew it was too good.
You don't get all their questions.
Yeah.
Okay.
So you're aware, of course, I assume that we continue to score really low on patient satisfaction surveys, right? And we have these benchmarks that we're looking at that are about readmissions and all these other things that somehow we're using, but the patients aren't feeling like they're getting care. So I wanted you to address that. And I also wanted you to address something we asked before, we look at slide 22, hospital factors of fluency, D, wait times. And what I don't see there is the availability of primary care physicians. And we all know we call up now and the first thing on the answering machine is if this is an actual emergency, hang up, because we're not going to take care of you, you need to go. We see consolidation of practices where physicians aren't incentivized anymore to take care of their own patients because it's too time consuming, it's too costly, there's not enough reward, and it's just easier to pass people off. And so I'm really interested in how you're viewing the system that we built that really disincentivizes providers from caring for their patients. And why is that not a significant factor when we're talking about going forward with the model and how we deal with some of the problems we're having?
So I'm going to take the second question first, even though it's one question, two questions in one. I'm going to take the second.
That is, if I may, a Delegate Hill special.
So, you know,
But they're great questions.
I just want to remind everyone, I was a primary care provider practicing every single day with what I will refer to as what's called 15-minute RVUs, meaning I had 15 minutes to see my patients. I only saw HIV patients that were very, very complex. And then I was managing multiple quality measures across different payers. So that right there sums it up. We've made practicing primary care too complex. And we did not address what we're proposing under the AHEAD model, but simplifying all of this for the primary care provider, for me personally, is certainly one of the things at the top of the list. We need to get providers re-engaged into primary care and create the access that people need to do the things that John mentioned related to the emergency department, because primary care access right now is difficult. I will say, when you look at the total numbers and you look at the number of primary care per capita that we have in the state, technically we have enough right now. They're just not spread out appropriately. They're concentrated in our highest population areas. And then as we go out to rural Maryland, we have less and less and less. Because of the dissatisfaction that you were talking with primary care, we're also seeing people choosing to leave primary care sooner than we expecting them to leave, and or limiting which payers they take or moving into concierge. So we have to figure out a way not only to simplify some of the administrative complexities we have with multiple payers, but as part of the model is, what should the primary care investment be as a total percentage of the overall dollar in healthcare spend? If we really say we value primary care as much as we value, and this is Laura personally speaking, maybe not as secretary, so I'm digressing as my whole life as a physician, we really have to put our money where our mouth is, right? And make sure that primary care understands that they are incredibly important in the delivery system as we think about ED wait times, as we think about improving health, improving the health of communities, giving a workforce that's ready to work, and managing people with complex chronic diseases. So it's absolutely on the radar, and we can provide more details on what that looks like. And one of the technical advisory committees is just focus on primary care. Now, to your first part around the satisfaction, I think all of these things impact satisfaction. If it takes me 30 days to get into a primary care, by the time I get in there, I might be annoyed that it took me 30 days to see my primary care provider. If I have to go to the emergency room because I'm sick and I waited in the emergency room for 15 hours, even if I got good care, they're still pretty upset that the fact that they had to wait 15 hours. So we're certainly looking at end to end and what is impacting people's access to care that leads to that dissatisfaction with our delivery system. But we have some obvious things that we need to change if we're going to improve that satisfaction.
Thank you. Sure. You're welcome.
To that point, I just want to make sure, and I think you would be, that you're also, it's not always just primary care. So when we talk about ER wait times in the previous decision didn't make, but I think everyone here knows the experience of somebody who had all their tests done, and 3 hours later, they were still there because they said, well, the doctor has to look it over before you can go.
Mm-hmm.
So it's not just primary cares. It is our whole structure that's at risk or at fault, I believe. And when you talk about the model and we talk about, hospital responsibility for communities, and how that feeds back. And we don't talk about systems when so many of our hospitals are organized as systems. I hope you're looking at changing that too as you readdress the model.
Yeah, I'm happy to talk about that. Yeah, I think as systems become kind of play a more prominent role within our state, and then also as the AHEAD model moves to some kind of broader accountabilities, we're going to be working with our partners to figure out how do we account for health systems and hospitals that roll up to a larger entity, right? I think that's one aspect of it. The other aspect of it is, as we think about more concerted population health focus, thinking about regional systems, right? So in other words, hospitals working together, working with primary care practices, even if they're not part of the same financial entity, they are part of a regional healthcare system, right? That needs to be matched to that community's needs. And so I think that is really going to be part of the policy focus as we move forward.
Thank you, Delegate Hill. We have the last question, Delegate Rosenberg.
That's a heavy burden, Madam Chair. How does, whoever wants to answer this, how does insurance coverage affect the patient's access to quality care in and out of the hospital, whether it is private insurance, Medicare, Medicaid, the Affordable Care Act, so on?
So I'll start. So it depends. It depends on what kind of insurance plan you have. So to a question that was asked earlier about some of the delays in access to care on the employer-sponsored health plan side, some plans are have high deductible. High deductible plans are often less expensive when you think about the monthly deduction that comes out of your paycheck. And sometimes based on the amount of that deductible, people will avoid care because it's expensive, especially hitting that deductible. Under the model, regardless of the payer, the goal is to get alignment of services regardless of the payer. So the care you do receive is equitable care, whether it's Medicaid, Medicare, or commercial. But there are differences in the commercial side and the employer-sponsored health plans, and certainly differences now with MA plans on the Medicare side of how people choose to access care, either because of copays or deductibles related to those plans.
Thank you. And I have just a question so that you can, if you know the answer, and I know you do, clarify for the committee. I know I used a term earlier. Can you please describe what does a frequent flyer look like?
So it depends on your definition. A frequent flyer can be based on the number of ER times they hit the ER. It could be the number of times that they're admitted for a chronic condition. So there's not one definition per se. It's usually how it's defined for an intervention.
But what do they have in common? However you define it.
Generally, they may have a complex chronic medical condition that needs management. They generally have some social needs that need to be addressed and haven't adequately been addressed. And some can have co-occurring behavioral health diagnosis, such as mental health and or substance use disorder.
Yeah. Thank you. And they often come back, right? A lot of times they repeat the visit.
Correct.
And I know that I have had conversations with Chris in the past about they're able to identify who these people are and how we can be, very intentional about targeting them to reduce the number of ER visits, right? To make sure that they stay in front of their illness and adhere to their, medication as well. So I want to thank you on behalf of the committee. I see no other questions, for being so patient, for having a really impressive presentation on what where we are today, where we're going to go ahead, right? No pun intended, as we discuss the model. I know that for the committee, there are those advisory committees. We have Delegate Bagnall and Delegate Collison from this committee that have been appointed to be on these committees, and Delegate Shetty, Emily Shetty, from appropriations, where our stuff goes to get funded. She's gonna be part of that as well. I know that they're looking for people, so if you want your community to be part of those discussions, whether you live in the rural areas in Western Maryland or the Eastern Shore in Baltimore City, wherever, Montgomery County, Frederick, make sure that you spread the word so that there's diversity, right, of regional in thought as well. All right, I want to thank you for your work. You're working so hard, and we really appreciate it. And I know that you're going to be with us for the last presentation as well. So thank you very much, Mr. Crum. Really appreciate you. And I know that you have someone with you that is new to the, would you like to say hello? No. Oh, if you can come up, but I have actually Deb. Can you tell the committee who you're with?
Hi, everyone. So if you haven't heard yet, I'm lucky enough that John hired me. I'm now the Government Affairs Director for the HSCRC. So if you have any questions, ask John. No.
And you were with?
You're more than welcome to come to me.
And you were with before? What role did we see you in here before?
I used to be, in my previous life, Vice President of Government Affairs for Care First Blue Cross Blue Shield. So I changed that name to HSCRC.
Well, welcome. We look forward to working with you. And we do have someone new actually to this committee as well. And she's going to be testifying with the secretary, and she's going to say hello to you. And it's we're getting right now an update on the Office of Minority Health and Health Disparities. And we have again Secretary Hera Scott, and we have Ms. Camille Blake Fall, who's the new director of the Office of Minority Health and Health Disparities. So welcome to our committee. I'm sure that sitting there, you sort of got a taste of the work we do that is very complex, but that we do it together. And it takes a village. So welcome to our committee. Secretary Hera Scott, would you like to start?
Thank you, Madam Chair, Vice Chair, members of the committee. Yes, I'm very excited to be here today to have you all meet Camille Blake Fall. She's got, when I took over as secretary, this office was really broken and neglected, and grants weren't going out, and certainly the charge of this office that's outlined in statute was not being followed. And we were lucky enough to get Camille to say yes to become its new leader. And under her leadership, she's made many changes in starting to move the office forward. So I'll just turn it over to her for the sake of time to provide an update on the Office of Minority Health and Health Disparities.
Thank you and welcome.
Thank you so much, Secretary Herrera Scott. It's great to be before you today. Chair Pena-Melnick, Vice Chair Coulson, the esteemed members of the committee. My name, as the Secretary has alluded to, is Camille Blake Fall, and I'm going to hold on to the newish Director of the Office of Minority Health and Health Disparities. If you love what I'm doing, I've been here forever. If you need to see more, I'm new. I am thrilled to talk to you today about the work of this office and the direction of this office, and happy to take any questions that you might have. But to center our conversation, I would really like to start by begging your indulgence to talk about the mission and vision of the office and where we are going. I think it's a great place to center this conversation. The mission of the Office of Minority Health and Health Disparities is to address social determinants of health, reduce health disparities, and advance equity by leveraging the resources of our department, collecting and compiling race and ethnicity data to improve health outcomes, fostering robust community public-private partnerships to advance health equity and education, and to guide generally the policies, practices, and program decisions of MDH, to influence the overall strategic direction of the department on behalf of the Secretary of Health. It is our vision as an office to achieve health equity where all individuals and communities in Maryland have a fair and just opportunity to obtain their optimal health care, regardless of ethnicity, sexual orientation, gender identity, or socioeconomic status. So that's a mouthful, but we are up to the challenge, and we look forward to partnering with all of you and our stakeholders and community, which is really why we do this work and where we do this work to advance these goals. For those of you who may be unfamiliar, and for those of you who are familiar, just as a reminder, this office was established by statute in 2004, and there are currently 22 areas of focus that direct our work. I'll highlight a few here. Some of the key activities include collecting and publishing race and ethnicity data through a healthcare disparities policy work report card, responding to data requests, and serving as a resource for information on effective data collection. We also advocate for improving minority health outcomes by establishing educational forums and programs, including grants to community-based organizations, and advancing health awareness campaigns. We work to identify and review health promotion and disease prevention strategies to address high mortality and morbidity rates among marginalized and underserved communities. We work to foster public and private partnerships, and we support and assist the Secretary of Health in setting health equity priorities for the department and advising on policies affecting delivery of that health care, and to ensure that the strategic plan meets the mark with respect to social determinants of health. In addition to this 2004 establishing legislation, which so many of you are familiar with, we have recent legislation over the last few years that advance this work. And I want to thank the committee for its ongoing commitment and efforts to advance health equity across the state. It's critically important, and we really appreciate your partnership in these efforts. I'd like to point your attention to 3 pieces of legislation. The HB 78, which was passed in 2021, which established the Maryland Commission on Health Equity, HB 309, which mandates that the department collects certain race and ethnicity data. And finally, HB 28, which is the piece of legislation that mandates implicit bias training for our clinicians in the state, and is shepherded by the Office of Minority Health and Health Disparities. So those 3 pieces of legislation advance the work of the 2004 establishing legislation, and I'll be speaking a little bit about all of those as we move forward. Next slide. Oh, did you move it? Thank you. So where are we today? MHHD is leveraging its resources to amplify impact. We are in a bit of a rebuilding phase. We up until about 2017 or 2018, I think that the office was sort of working at a steady clip to meet some of its mission. But since then, that we have been working to recenter the work of the department and ensure that we are meeting our legislative mandates. And we are excited to be working under the leadership of Secretary Herrera-Scott and with all of you to advance this critically important work. Some of our current initiatives I'll highlight here include our recent National Academy for State Health Policies Learning Lab participation, where MHHD is leading the Maryland cohort in this multi-state technical assistance opportunity that supports the state in data-driven policymaking approaches to address health disparity. We're also supporting the Maryland Commission on Health Equity, which through data support, and we are helping to develop a health equity framework. The MHHD director, myself, and the epidemiologist, I serve as the chair of the committee, and the epidemiologist supports the work of the committee. In addition, we have a 2023 report that some of you may have seen that was authored in large part, the data advisory piece was authored in large part by our office, and we are actually, you may not have seen it just yet, but it is coming, so stay tuned. We track 5 social factors, 5 health outcomes, and by county, and sort of do some high-level analysis of what we are seeing across the state in terms of inequity. Finally, I'd like to highlight the root causes of health initiative quality assurance program, also known as ROCKY, where MHHD and the Public Health Administration within the department are working on looking at the root causes of health disparities. And we are looking at that through an equity of reach and equity of impact lens. In addition to that work on the data side, and that was really all data driven and data focused, we've got 3 grant programs with two being developed that we administer to provide direct services to our communities here in Maryland. The first is our oldest, is the Minority Outreach and Technical Assistance Program, or MOTA. MOTA actually precedes the establishment of this office, but its mission is to improve health outcomes of racial and ethnic minority communities through community engagement, partnerships, outreach, and preventative intervention strategies. We also have these 3 are fairly new, well, they are new, the 3 new programs: Social Determinants of Health program, which helps to support community partners reduce health equity by providing community-based interventions. Our COVID program, which is the Epidemiology and Laboratory Capacity program, which provides community-based services, including outreach, education, and other COVID response-related support. And finally, our sickle cell program, we are the fiscal stewards of funding to support the Maryland Statewide Steering Committee on Sickle Cell Disease. The legislation, the establishing legislation in 2004 laid out several requirements via statute that for the office in terms of directing our work. And we have focused on several areas. We focused on all of those areas, but in some they involve collecting and disseminating up-to-date race and ethnicities data, responding to data requests and serving as a resource for that information, engaging in a department-wide health equity inventory of our current portfolio of programs and policies to ensure that health equity is embedded throughout and across the department, developing and promoting internal and external practices to address structural racism and reduce the impact of the social determinants of health, including understanding the most effective means of providing outreach to communities, strengthening community capacity by partnering with community health workers and community-based organization. And last but definitely not least, sort of most important in my mind, is identifying effective and feasible systems levels interventions that can help reduce health disparities. We do this work inside, along with under the leadership of Secretary Herrera Scott and the broader department, and we're looking to align our work with the priorities of MDH. And so we do that by providing funding opportunities to community partners through grants, supporting the department's overall legislative and policy development efforts, including in the areas of population health, Medicaid engagement, and behavioral health system of care. We collaborate with and advise our colleagues on health equity and disparities initiatives, and we serve as a resource for cultural competency training, including implicit bias training, language access training, and programmatic technical assistance. We do this work in partnership with our colleagues and also with the local departments of health, healthcare, and community-based organizations to help identify health equity challenges at the grassroots level. Looking forward, our office is starting to understand the areas under the statute that require further development and alignment with our current work, including a focus on creating a state plan to increase the number of racial and ethnic healthcare professionals in the state. I serve on various commissions within the Maryland Healthcare Commission ecosystem and help to sort of bring forward the issues we are hearing on the ground in community when we're partnering with our community-based organizations about what is sort of most effective to advance this work. We partner with institutions, academic institutions like Morgan State University. We identify federal and private funds to enhance this work, and we serve as a central office for receiving federal funds related to healthcare disparities. Looking to the future, we will work within MDH to drive health equity objectives. We will develop and adopt a shared definition of health equity and a health equity framework. We have begun the process of designating health equity officers within each of the major offices, units within the Maryland Department of Health. And most importantly, we will build the agency's capacity to understand and embed anti-racism equity practices throughout MDH's operations, including its systems design, its contractors with its contracts with vendors and providers, its budgets. We know that budgets are moral documents, so we should be seeing our equity work there, internal and external communications, and workforce development. We'll do this through training and opportunities for accountability, which is key. We look forward to the opportunity, I speak on behalf of the department and my office, look forward to opportunities to work with this committee to enhance health equity throughout the state through our current and future work. Thank you so much, and I'm happy to answer any questions you might have.
Thank you. I see Delegate Martinez, followed by Delegate White, followed by Delegate Collison. And thank you for your presentation. Really appreciate it.
Yes, thank you, Madam Chair, and thank you both for being here. My question is for the director. I think we can agree that it's essential when connecting with new Americans, particularly those from Spanish-speaking countries, that we have staff in our departments and offices that speak the language, but also reflect those communities. Could you tell me the number of Latinos that work within your office and those that speak Spanish?
About first and foremost, soy puertorriqueña, habla español. Okay. Keep going, sorry. I would be remiss if the leader didn't say that she was Puerto Rican. So.
As I mentioned earlier, we are in a rebuilding phase. Right now, we have 5 staff members, one of which is bilingual, speaks Spanish and English. And so we are hoping to, with the support of the secretary, we will be increasing our roles, our employment roles, so that we will include a more diverse representation. We also have, I throw this in for good measure, we recently hired an employee who's gender nonconforming and sort of helps us identify some of the issues, boots on the ground there. So we're looking to diversify our staff, and with that sort of the perspective and the focus on sort of what's needed in the state and the voices at the table, which is sort of key and central.
Someone who checks many boxes, pretty much almost all of them. And so I want to make sure that in our departments that's reflected just as what's in our communities as well. So I look forward to working with you on that.
Wonderful. Thank you.
Thank you. Delegate White.
Thank you, Madam Chair.
You're welcome.
I'm particularly interested, and again, thank you so much for your update. I'm particularly interested in the outcomes around the implicit bias training, and I wanted to know, do we have any data available that can tell us how many providers to date have been trained? What have those outcomes and responses and feedback been? Again, I think it's really important that what gets measured counts and can hold us accountable. And so while we are appreciative of the really focus on data and creating these frameworks, is there any data that you can provide back to us? And maybe something that could also be shared with this committee related to the providers that have been trained to date and some of the other outcomes related to this particular bill?
Thank you, Delegate White, for that question. That's a wonderful question. The bill language specifically requires that we endorse or approve, if you will, evidence-based training for each clinician in the state. And so it's fairly prescriptive in its requirements. That isn't to say, there is another piece, but it doesn't answer your question. That isn't to say that we can't find a way to gather that information from the various boards that are doing the licensing. And it's a wonderful recommendation, and we should absolutely take that up. The other recent focus of ours with respect to the legislation is to ensure that all of the individuals who are sort of being licensed are sort of thinking about work through a race equity lens. And so the training has to be culturally competent and sort of responsive to the needs that we see. So we are happy to partner with your office and sort of think about more broadly how we can address the question of making sure that we have a sense of like who is actually participating in the training and where the gaps are.
And if I may, I know that the boards have that information. So if you can submit that to the committee, please.
Okay.
And actually send it to Delegate White and CC the entire committee and council. That would be great. Thank you, Delegate White. That's a great question. I have Delegate Collison, followed by Bagnell, followed by Morgan.
Thank you very much, Ms. Blake Halford, for taking on this momentous task. I mean, it is truly just seeing all the requirements and the mission and vision of the department is really, you recognize what a big job it is, or I recognize what a big job it is, and I appreciate that. So one of the things that we've heard is, as we think about health equity and as we think about how we move forward in developing healthcare in Maryland, we're looking at making sure that our communities are engaged and are involved in and are informed about the different options and opportunities and the programs that will help them. So I'm wondering if you have or would consider whether or not there is a natural sort of integration with your department and the Community Health Resources Commission, which, you know, is granting, you know, presenting or providing grants for the kinds of activities that the department is trying to foster.
Thank you for the question, Vice Chair. Yes, I'm actually a member of the Community Health Resources Commission. I'm working closely with Mark Luckner and Nellie Washington, who serve on that committee, to advance these very initiatives. We have many robust conversations, most recently about the HERC grant and who could be at that table, sort of like, you know, how do we welcome, how do we make it accessible to our smaller community-based organizations that are really doing work on the ground, in addition to the larger systems like the University of Maryland and Hopkins. How do we ensure that we have diversity of thought, diversity of reach, diversity of practice? And so we've absolutely been working with Mark and Nellie, and I work closely with them to sort of help refine the grant that recently closed, the grant opportunity. There were 53, we were excited to see that I think 51 or 53 applications were submitted, which is really robust and diverse in terms of their scope and opportunities for reach. And so I think that we will the office, MHHD, under Secretary Harris-Scott's leadership, will continue to be thinking very granularly about that.
I think that's a natural partnership.
Sure, right.
Thank you, Delegate Bagnell, followed by Delegate Morgan.
Thank you, Madam Chair,
My
and
pleasure.
thank you, Madam Secretary and Executive Blake Fall for being here and for your presentation and your commitment to this work. I know we're all looking forward to seeing that 2023 report. But one of the things that you stated as a duty of the office was to collect and publish race and ethnicity data and through a health equity disparities policy report card. Can you update us on when that report card was last published and how, under your leadership, the office plans to implement the report card requirement and make sure that it is accessible to the public?
Thank you for the question. I don't know that I have seen a report card that precedes my time in the office. I started in July of 2023, and but it is absolutely a mandate that we are currently working on. I will note for the committee that some of the metrics are only collected annually, right? So the every 6-month update is something we're thinking about. Does it make sense to repeat the data from annually for those metrics that are only annually obtained, or do we, and for the ones that are biannually obtained, do we, you know, like what will be the best way to provide that information? But since I joined the office just under 6 months ago, it is a priority to sort of meet that mandate legislatively and figure out the best way to deliver that information to you and the other members of the General Assembly who would find that interesting, and really to the community. So that's been an area of focus of mine, and I look forward to working with your office and everybody who's interested to sort of keep you up to date about where we are and sort of really getting that off the ground.
All right, Delegate Morgan passed. So I want to thank you for coming. I don't see any other questions. I do want to know, when should we expect the 2023 report? Because the last time it was done was in 2020.
The 2023
report, when would it be finalized?
The one that's the biannual, the one that's,
Yeah. The 2023
Yes, yeah,
report?
sorry,
Yeah.
I've got so many reports that are
Yes,
running,
okay.
so that the legislative language requires us to get that report to you by the 15th of January.
Okay.
We will not be but we will only miss that mark by a couple of weeks. So the team and I are working to get an initial draft to Secretary Herrera Scott and her team by January 30th for their review. At which point, once we refine it, we'll be ready to sort of send it to you. So or to publish it. So that's the timeline with which we're working.
Thank you. We
Yep.
appreciate that very much. And then the last question is regarding the report card. I understand that you can have it, that it's tough every 6 months, but we need that updated.
Okay.
So even if you did it once a year, when could you expect to have that done?
I will take that back to the team and ask them. Right now, we're working on our as we just referenced, we're working on our annual report on that we were just discussing. But we will turn our attention to that immediately as well, concurrently, and report back to your office about when you can expect to receive that in short order.
Thank you. And then also there are going to be actually there are quite a few bills that will affect your office. So what we would like to do is to welcome your voice, your position, to let us know what you think about the bills and to work with us. There's the Black Caucus particularly has a legislative priority, which is maternal health. As you know, Black women die at a rate 4 times higher than white women, and it doesn't matter what level of education you have. And that is one of our #1 priority. I belong to both the Black Caucus and Latino Caucus. And I know that Delegate White, that is her bill that she's working on. And she has been in touch with the Secretary Marie Grant as well. So I welcome your partnership to work with any of our committee. Our committee has 23 members, and to reach out with us and let us know, what policies you would like to advance as well, okay? Secretary, thank you so much for all your efforts, for working so hard. It really shows, and for being a partner. We really welcome it, everyone on this committee. Thank you so much.
Just a reminder, I'll be back here tomorrow.
We will welcome you again. And for the committee, can you, after we are off, can you just give me 1 second? I just have a quick announcement. Thank you, everyone, for being with us, okay?